Hello everyone, welcome back to our NCLEX RN Review. So for those who just joined us, we are on the second day of the 90-day free NCLEX Review classes, which we'll be doing daily at 12 p.m. Eastern Standard Time. And so we'll be covering all nursing subjects and rationalization of 2000 NCLEX style questions. So for today, I'll talk about the nursing care and management for a patient with peritoneal dialysis, and we'll have some Q&A about the AKI, or the acute kidney injury, and chronic kidney disease, which we talked yesterday. Now, to get started, we'll talk about peritoneal dialysis, which is a vital medical procedure that is used to treat individuals with kidney failure by removing their waste and also excess fluid from the body. So unlike the hemodialysis, the peritoneal dialysis will rely only on the body's own peritoneal membrane as a natural filter. Now, I really want you to focus on this because this is actually a quick and simple procedure, as just like when you're studying, right? But with the processes here involved, we'll start with the fill phase, wherein this is the first step that is going to involve introduction, or the infiltration, or let's say infusion rather, of the dialysis solution into the abdomen, and this will be done through a catheter. And so this is a solution that is actually a mixture of sugar, water, and also essential minerals such as sodium, potassium, and calcium. So the mixture is actually a kind of like a hypertonic kind of solution. So it will act to draw those excess fluids in the peritoneum and also draw those excess waste products. Now, it's going to be followed by the dwell time, wherein the solution is going to be allowed to stay inside the abdomen for quite a while. And it will now absorb those excess fluids and the waste products from the patient's body. Now, the drain time will be the exact phase wherein the solution is now going to be readily available for drainage. And so it already has absorbed those excess water and also waste products from the patient's abdomen. Now, I'll show you here about what it looks like to have a patient, of course, with the use of the dialysis solution. We have the bag here, we have the patient's abdomen. You'll see here the catheter and the tube that will be used to instill the dialysate into the patient's abdomen. And so again, this can be done at home. Even some patients can do it even when they're doing their daily activities. This is what we call as ambulatory type of dialysis. And so they're going to be given some kind of free rein to do their daily activities at home. And so this is one of the advantages that a patient can really enjoy when they're going to have to use the peritoneal dialysis. Now, one of the indications for the peritoneal dialysis, or I'll just refer it to as the PD. So this is going to be quite beneficial for the adults, especially the older ones, who are going to need the dialysis. And this is something that can be easily tolerated for those patients that may have had adverse reactions to the heparin, which is actually the anticoagulant to prevent the blood from coagulating in the dialysis, the hemodialysis, I should say. So with the peritoneal dialysis, it doesn't involve the use of any heparin, none at all. And so this is something that can also be indicated for those patients that may have had problems with their vessels, that there might be some trouble in finding those good arteries and veins to look to actually allow that fistula to mature. Now, this is also going to be indicated for those people that may have unstable medical conditions, or maybe they have some chronic infections. And this is also going to be beneficial for those patients that may have chronic diabetes mellitus, or for those people with heart failure or severe hypertension, because there's a whole lot of things that can be involved when a patient is going to go for a hemodialysis. Now, we'll tackle here the different advantages of the peritoneal dialysis. Again, this is going to be very beneficial for those patients with chronic conditions like diabetes mellitus, heart failure, also for those people with hypertension, and because of its gentle fluid removal, which will actually help stabilize the blood pressure. Now, it also has some flexibility in the treatment schedule. So they're going to be able to do this at home in their own private time. They can also proceed with doing the peritoneal dialysis even during the sleep time. And so the patient that will also be doing with a PD, they will have much better glucose control because the PD makes a favorable option for managing multiple chronic conditions effectively and also managing their blood sugars. Now, moving in towards to the nursing action. So we're really going to have to break down what happens before a peritoneal dialysis procedure from a nursing standpoint. And so before the procedure, there are a lot of things that we need to get done. So we need to better have some checklist, especially if you're a newbie. You better have some checklists so you can go over what those needed equipment or also requirements that need to be completed before we can go ahead and start the procedure. Now, first things first is to make sure that we have to gather some information and also the proper measurements in order to ensure everything goes smoothly. So we are going to obtain the patient's weight. I'm talking about the dry weight, which is actually the weight without any excess fluid. So this is going to be done right after they voided. And this is along with their baseline vital signs as well. So again, this will include the blood pressure, the heart rate, temperature, respirations, pain level, oxygen saturations. And so these information will actually be used as baseline data and then will be compared by the time when there is a subsequent vital signs monitoring in order for us to look back if there is significant change or if there is, let's say, deterioration or let's say improvement in the patient's status. Now, along with the baseline vital signs, we also need to check for the patient's electrolytes, the creatinine level, the blood urea nitrogen, the BUN, and also including the glucose levels. So I really want you to take a bit of a moment here to just focus on what these preparations are. Again, we're going to focus into obtaining first the dry weight, the vital signs, also the labs, especially the serum, creatinine, BUN, and also the electrolytes, including the potassium, phosphorus, calcium, sodium, and also the glucose. So make sure that you have those in your checklist. Now, onto assessing the patient at this point, we are going to check if the patient that we are going to be treating is able to handle the peritoneal dialysis on their own, because this is something that will be done at home upon discharge. So for example, we're talking about starting the peritoneal dialysis in the hospital setting. That's why I mentioned all these preparations. And so we are going to identify or to assess the client's capability if they're able to manage the procedure and also to maintain the sterile environment when they will be at home. And including that, we are going to also measure their alertness level, and we have to find out if they had any experience in the past, if they had dialysis before, or if they're able to understand about the procedure. I'm talking about the instructions. Would they be able to follow the guidelines? Because some adverse effects or adverse reactions, or let's say adverse events, can happen if they'll be doing a whole lot of things that is against the guideline. They might be harming themselves if they'll be inserting their dirty hand into the inlet of the PD axis. So we want to make sure that they do have that understanding, their mental capacity to really go through the different steps. Now, part of the care here is to make sure we are to educate our patient thoroughly and we want to know what to expect. And we will be explaining to them what's going to happen during the dwell time of the procedure. And we want to make sure that they will understand that they're going to feel some fullness and also discomfort in their abdomen. And this is something that is expected. And so they don't have to worry about the discomfort, because this is something that will kind of diminish after several sessions of the PD. So this is something that can be totally diminished after at least 2 weeks of continuous PD or intermittent PD. Now, at this point, we're going to have to stress the importance of sticking to the procedure guidelines in order that everything goes smoothly. And for those patients that will be using the continuous ambulatory peritoneal dialysis, or we call this a CAPD or CAPD, they're going to be doing the daily sessions that would last anywhere from 4 to 8 hours. And they can do it at home while they're eating their meals, or maybe watching their TV, or maybe doing their hobbies at home, or maybe when they're in bed. And for those patients that may be having the automated peritoneal dialysis, it's quite a bit different, because this is going to involve a much shorter session, about 30 minutes of exchange that will be repeated over 8 to 10 hours while the patient sleeps. And so with this kind of modality, it's all about finding what works best for each patient. So at this point, before we're going to dive into the meat of the matter here, we're going to have to make sure that all the necessary information and measurements will be able to capture. And so we want to make sure that the patient is ready. And we also will give them a heads up of what to expect during the procedure and their treatment schedule. Now let's go to the next section of our discussion, which is actually the nursing actions that will be involved during the procedure. All right. So what are we going to do at this point? We are already in the session. And so first things first, again, we're going to have to obtain baseline and also frequent vital signs. And this will allow us to monitor frequently throughout the procedure to make sure that everything is running good. Now, next to that, we're going to have to check the blood glucose level. Because the dialysate solution, I said that it was a hypertonic solution, right? It's composed of some sugar, it's composed of some electrolytes. And so the glucose of the patient, the level of the patient's glucose will be needed to be checked, because this dialysate solution contains sugar. So we want to keep an eye on the glucose level to ensure that they're going to be in the safe range throughout the procedure. Now, here's where things get a bit technical. So we're going to carefully document the volume of the dialysate going in, and we're also going to compare it to what is coming out. So this is something that can be easily neglected, mind you. And so we need to have some consistency. We want to make sure that the amount of the solution going into the patient's abdomen will match or at least exceed a little bit of what's going to come out from their abdomen. Because if the amount of the fluid that will be coming out from the patient's abdomen is lesser than what we have infused, then something is not right there. So maybe there could be some obstruction, or maybe the solution has some problem in it. And so we want to make sure that we are measuring that amount before we instill and also after we drain the solution. Now we're also going to monitor or check the color of the dialysate. So we're going to keep a close watch on the color and also the amount of fluid. So I am talking about the effluent here, okay? So when it is going to be drained, the expected normal color would be clear, light yellow. Again, that is clear, light yellow. I didn't say anything else. I didn't say bright red. I didn't say anything brown. I said light yellow. That is normal. And the amount of the if effluent actually will be at least equal or it would be greater than what has been infused. Now, of course, you're also going to look up for any signs of trouble, right? So another very important element here is to make sure we are looking for that cloudy or bloody dialysis, or let's say fever. So this is something that is commonly asked in NCLEX. How are you going to determine if your patient is safe to go through with a PD? Well, if you're going to find that the patient now has elevation of temperature, there is cloudiness in the effluent, or let's say the dialysate now has some bloody discoloration, it's pink tinge, or let's say it's frothy. Now, these are indications that there is an infection going on in their abdomen, and this is what we call as peritonitis. Not fun. And so this is one of the complications. Aside from that, there's also going to be respiratory distress or abdominal pain, and also maybe there are some complications as far as maybe bowel perforation or the perforation of the bladder, or maybe there is an erosion into the blood vessels inside the abdomen. So these are the commonly asked situations in the NCLEX. How are you going to tell that the patient is safe to go through the PD? And which things are you going to report immediately to the provider? So I really want you to focus these things, because we are going to be asked on how good we are assessing the patient. Now, we're also going to have to keep tabs on the access site dressing. And so we are going to check for the moisture, also the wetness of the dressing, to see if there's any signs of infection. Okay? Now, another possible question that could come out in the exam is maybe how are you going to warm, or how are you going to teach the patient to warm the dialysate? Because we don't want to, or we don't want them to instill a cold dialysate into their abdomen, because this is going to make them so crampy. It's going to be painful to go through if the temperature is not the same with the internal body temperature. So we want to make sure that this is warmed properly. But the question is, how are we going to warm this? Well, it said here that we're not supposed to use the microwave. Yeah, we don't. Because if we are going to use the microwave, it will actually affect the consistency of the elements inside the hypertonic solution. And so it will not be effective anymore. Maybe it can cause some complications during the session. Now, instead, what we're going to do here is to instruct them, or if it's in the hospital setting, what we're going to do is to wrap the bag of the solution, which is actually sealed in a plastic bag. And so we're going to wrap them in warm blanket to warm the solution, maybe for good 15 to 20 minutes, in order to let it be at least 37 degrees Celsius, or let's say 98.6 degrees Fahrenheit. So again, the temperature should be close to the body temperature. We don't want to use the microwave. We only have to use warm blankets, or let's say we're going to have to place the sealed bags on the sink or in the sink, and we're going to have to run warm water to allow the change in the temperature of the dialysate solution. All right, so I hope that you were able to capture that. And so at this point, we're going to have to really stick on the schedule like a glue, right? And so we want to make sure that we follow the prescribed times for the infusion, the dwell time, and the outflow. That is part of the prescription by the renal doctor. We cannot decide on our own. Maybe you're going to think of, I'll just let it stay for good 8 hours. No. Or maybe you allow the infusion way too long. This will cause some problems into your patients. We want to make sure that you're adhering to the prescribed dwell time and also the drain time. Now at this point, we really need to make sure that when the patient will be sent home, or even the hospital setting, it's very important that we're actually showing them how to do it the correct way. And so when we are placing the outflow bag, we want to make sure that this is something that would be placed below the abdomen in order to ensure proper drainage of the effluent. Because if it's at the same level of their abdomen, then it can cause sluggishness in the outflow, it can cause fibrin clot formation inside the tube, and it will clog the drainage. It's going to be a problem, right? Now, if there is a situation wherein there is now a problem with the drainage, it has been several hours already, and the drainage has not completely emptied the patient's abdomen. And so at this point, we really need to be prompt in assessing the patient that maybe within this time frame, within an hour, there's already a change in the size of the patient's abdomen. There should be already a good amount of collected effluent in the drainage bag. And so if you're going to check your patient maybe way too long, you didn't come in and check the patient's drainage bag and it's been probably 5 hours already, well, that is a big problem. What we're going to do here, if there is a problem with the drainage, we want to make sure that we are going to reposition the patient. All right, that is one step to resolve. We want to make sure that maybe try to reposition them to one side first and then shift to the other side, and to see if there is some movement of the drainage from the abdomen to the drainage tube and to the drainage bag. So this is a very common NCLEX question, so I want you to remember that. Now, if in case there is a formation of a fibrin clot, it's no fun. When a fibrin clot decides to crash the party and it forms around the catheter, no worries though. If you're a pro, then you can resolve this. So what we're going to do here is we will gently milk the catheter, and in order to break it up and keep things moving smoothly. All right, this should resolve that. Now, last but not the least is that we're going to have to provide emotional support to the patient throughout the procedure, especially if they're a newbie to this kind of procedure. Maybe this is only their first, second, or third time. And so this is something that is new to them. Maybe they're feeling something weird inside their belly, cramping. They just don't want to tell the nurse, or maybe they're just afraid to ask. And so we want to make sure that we are supporting the patient in order that they can open up and we can support whatever concerns that they might have. We can answer those questions as well. Now, we're going to have to talk about the nursing care that we will be providing to the patient after the procedure. So first off here, we're going to have to keep a close eye on the patient's weight. Why? Well, the reason that we need to weigh the patient one more time is to see if there has been any changes, okay? So if the weight post-procedure is maybe heavier compared to the baseline, that would be worrisome, right? If the patient did not really eat too much, or maybe they did not take any fluids at all. So that would be concerning. And so the reason really is to make sure that we are following up if the dialysate solution has done its job in drawing those excess fluids from the peritoneal cavity, and also doing its job in drawing those waste products from the patient's body. And so that's the reason we really need to compare the baseline weight and with the current weight after the procedure is done. Now we're also going to check the patient's electrolyte levels, also the creatinine, the glucose, also the BUN, to make sure everything is in check, okay? Now, if I'm talking about electrolytes, I'm actually referring to the potassium, the calcium, the phosphorus, and also the sodium, because these are the main electrolytes that we will be checking on. Because as we know, with CKD, or chronic kidney disease, there's huge imbalances among these electrolytes. Now, next up here, we're going to take care of the access side as well. And so it is very important that you're going to practice strict asepsis or surgical technique in taking care of the access site. And we want to make sure that we're going to keep the site clean and dry and also to make sure that we are checking for any kind of infections from sneaking into the access device. Now, another thing that we need to really emphasize on is to make sure that our patient is able to perform their dialysis exchanges at home, and also to seek assistance with the National Kidney Foundation for support if they have any doubts or if they need some more education about the treatment. Then they can freely schedule and make a call in order for them to get the support they need. Okay? Now, another thing that we need to do is to make sure that our patient will stick to the instructions and also the medication schedule, because it's very important that they have to keep that consistency with regards to the medication schedule, when is the best time to take it, in order that they can better manage their health while they are dealing with this new change in their treatment. Now, another thing that we need to keep an eye on is about the nutrition, okay? Let's not forget about the nutrition, because what if they're only doing the dialysis, but if they're not really following the recommended renal diet, they're going against what is recommended, then definitely all those dialysis treatment is not going to do anything for them, all right? So if they're eating on trash, garbage, and so the dialysis will just be nothing, all right? So we want to make sure that our patient is also following on taking in the essential minerals and also the vitamins that they need in order for them to keep or to stay healthy. And we're talking about also keeping on to the dietary changes in order that they're getting what they needed. And so for those older adults, they might need some support. I'm talking about much more of the support, let's say, and assistance. Maybe a family member or a caregiver would be needed in order to help them with setting up the machine, because they're actually going to be losing a lot of their dexterity. Their skill is somewhat kind of diminished. Their vision is affected, even though they have all the eyeglasses in the world. Or if, let's say, they're not really wearing their eyeglasses or the hearing aid, so they will not be able to really follow the instructions if they're not going to be able to communicate properly with the caregiver. And so the help of the caregiver, a family member that has been taught to deal with a PD, can do a lot of wonders at home. And so this time, we're going to have to also deal with any concerns about body image, because bloating is a common side effect of peritoneal dialysis, and this is very important for them in order that they can express those feelings about being uncomfortable with the way they look, and so that we can support with those emotional needs that they have. Now, we're also going to talk about the different complications about the PD. There are many complications that can happen to your patient, even if you have already have done your best in educating the patient. Maybe they have already touched bases with the Kidney Foundation, or maybe they had a caregiver at home, even the support that they already had at home. Things can go wrong unexpectedly, so you just have to deal with it. Now, one of the complications that we need to manage is basically the peritonitis. This is a common NCLEX scenario that will be asked, okay? Peritonitis, this is the infection of the entire section of the abdomen, inside the abdomen, where the effluent or the drainage, or let's say the solution has come in contact with. And so if there is, let's say, a break in the aseptic or surgical technique in touching all of those catheter, or the way how the bag has been spiked, maybe there is a break in the aseptic technique. Maybe somebody touched the portion of that spike with their bare hands, without hand washing. Then this can really cause the patient to have that peritonitis. Now, one of the key assessment finding when there is peritonitis is actually the presence of a leakage from the dialysate. That is one sign, okay? So I really want you to be reminded about that, the leakage of the dialysate. And so what is the preventive action that we can do here? Again, we'll start with strict surgical or aseptic technique when we are dealing with the tubing and also accessing the PD device. Now we're actually going to have to monitor for the moisture, the wetness, the dressing surrounding the access device, and also to check for any leaky catheter. This is one step. Now, also we're going to have to look for any signs of infection. Let's say purulent drainage, let's say swelling on the surrounding side. Maybe there is now some kind of like redness, edema surrounding the insertion site. There probably is fever. The patient has been telling you that they have had chills for 2 days already. They feel so fatigued for maybe 24 hours. They haven't eaten their meals for maybe 6 meals already. That is significant. And so you're going to base your assessment also on what they're going to report to you, what they have felt in the past 24 hours. These are key subjective findings that you really need to pay attention to, okay? Because this could be signs of infection. Now, we want to make sure that we are checking for any type of moisture around the catheter to catch those leaks. And we have to make sure to teach our patient about the sterile techniques and also the caregiver, whoever is helping them, whatever signs that they need to look out for in case an infection happens. Now, part of the education to the patient is to make sure that they need to avoid any accidental tugging, okay, or twisting the tube, which could cause some issues. So that is one teaching here, that they need to avoid tugging, twisting the tube, and they need to notify their care provider or medical provider if they're gonna experience those fever, chills, or any signs of leak from the dialysate, okay? So those are signs of peritonitis aside from the chills and the fever. Now, we are gonna have to keep an eye also on the serum albumin, because the procedure itself, the PD, can cause protein loss. So we cannot help about the protein loss, really. It's just gonna happen. And this is one disadvantage about doing the PD. But there are some interventions that we can do to mitigate this problem. And so what we can do here is we are going to monitor the patient's albumin level through the blood study. So this is something that can be ordered by the physician and have it drawn so we can monitor if they are having low albumin level in the bloodstream. And so if the albumin level is going to go low, it will cause a whole lot of problems. It will cause the fluids from the vascular compartment to leak into the interstitial spaces, the tissues. It will allow those intravascular fluid to go into those spaces that fluid should not be able to go in a normally functioning body, let's say the peritoneal cavity. And so this can cause some more problems if we are going to monitor the albumin level. And part of that would be its effect on the, the vital signs. The blood pressure will be considerably affected if there is low albumin, okay? So it can cause some hypotensive episodes in the patient, and also with the medications that they are taking, if there is low albumin level in their system, some of the medications that they are taking could be more toxic to them, because the medication will have a much faster or rapid effect into the tissues. If these medications are highly protein bound, they are going to go directly into the tissues to cause an immediate effect. Because supposedly, when a medication is called as a high protein bound, before all of those doses will be be sent into those receptors into to the body tissues, these are going to bind into the albumin first in order that when those medications have kind of been used up already to the tissue, so the remainder amount of the medication will also dissipate and they will detach from the albumin and they will go into the body tissues to work, and also that they can do its therapeutic effect. And so, like I've said, if there is low albumin content, the patient is prone to developing toxic effects of the medications. Like I said, let's say, for example, one of those toxic medications would be ibuprofen. Or let's say if they're taking some form of anticoagulant, maybe warfarin. This is a highly protein-bound medication. And so if the albumin level is low, the medication will readily, immediately do its job. The drug action will be much faster, which is not going to do anything good for the patient because it should not work that way. And that is why we definitely need to check the albumin. Now, we have to encourage the patient to stick into their diet, especially renal diet, and I'm talking about diet that is high in dietary protein. But they are going to be low on the content for the phosphorus and also the potassium. So these are the food items that will be high in dietary protein. We have the lean meats, the poultry, fish, eggs, and dairy products. Okay? And so these are the better options in order that the patient will have will prevent any kind of elevation in their phosphorus and potassium levels. Now we're going to have to proceed into the other complications. So one of the other complications is hyperglycemia. Now why is hyperglycemia going to happen? Well, it is because the solution that we're administering is actually a hypertonic solution. So there's a chance that this can potentially cross over and will cause some hyperglycemia into the patient. And also, what we're going to do here is to make sure we are checking the patient's glucose level. We have to do it by maybe checking through the finger stick blood sugar, which is a very simple procedure. We can readily know what their blood sugar at that point. And if there is a prescription to administer their own insulin, maybe it's a long-acting or intermediate or short-acting or rapid-acting insulin, then they can give or they can self-administer the medication if they're able to do it in order to cover the blood sugar that they are seeing in the monitor. Now, another problem that we can encounter is hyperlipidemia, which is going to be an elevation of the triglycerides. Kind of counterproductive, right? But things happen. And so hyperlipidemia is one of those complications that can occur in a patient with a PD. And so what we can do here is to check for the patient's triglycerides, their lipid panel, to see if there is a considerable elevation of the LDL or the triglycerides. And so if it's already affecting their blood pressure, then what we can do is to make sure the medical provider is aware about the change, and then maybe they can get their prescription for an anti-lipemic medication or let's say antihypertensive medication, or maybe some better options, maybe some good diet options or exercise, right? We're not just going to talk about pharmacology, but we're also going to incorporate those other holistic approaches. Now, we are going to talk about some problems with the outflow and also the inflow of the dialysate. So this is something that could become tricky as well. And this could be caused by a simple constipation. Imagine that. Constipation can cause the outflow of the dialysate solution. So maybe the patient probably did not have a bowel movement for 3 days, or maybe 4 days, or even 5 days. And this is quite true. I've had patients that had no bowel movement for 7 days. And so if this is a patient with a peritoneal dialysis and maybe they had constipation for that long, then we're going to have to deal with that, right? And so maybe if there is clot formation, clogging the catheter, that could also cause some problem into the outflow. And same thing maybe with a catheter displacement. And so this would definitely need some revision and replacement of the catheter, and maybe an obstruction or twisting of the tubing. So these are possibly one of the main issues. Or maybe the positioning of the patient. Maybe the position is kind of like causing some kind of like a trap within the abdominal cavity. Maybe there is some kind of a malformation of the catheter inside the peritoneum. And so this is going to really affect the outflow. Now, we can do some troubleshooting here, and this is something that we can teach our patients. Now, first things first is we can allow them to reposition, maybe to let them shift their position from one side to the next and see if there is any flow after they reposition. And if not, maybe try another position. Or if this doesn't work, then they can do some milking of the tubing. Maybe there is fibrin clot formation that can be easily fixed by just compressing or milking the tubing. And so we're also going to check for any kinks or maybe clamp that has been inadvertently closed, and also to prevent constipation. So how are we going to deal with that? Well, we're going to have to initiate a high fiber diet, and also we can probably consult the doctor or have them talk to their medical provider to prescribe them some stool softeners, or maybe over the counter. But still, they need to talk to their medical provider if they need to get OTC, because some of these medications potentially can be contraindicated with their current regimen. And so everything needs to be checked off by their medical provider. And so let's go back. They could make use of a stool softener, maybe a laxative, maybe Colace, Senecot or Senna, maybe some Dulcolax suppository. So these are possible, or Miralax, some of those Miralax powder that they can mix with some water in order to treat the constipation. Another thing that they can do as well is to reposition themselves, of course, with the head of bed slightly elevated during the dialysis in order for the fluid to properly drain by gravity. Now, aside from that, we're going to have to keep an eye on the outflow. If there's any change in the color of the outflow, maybe it's now transitioning into a brown discoloration, or let's say reddish, bright red discoloration, maybe that becomes bloody. This could become a potential issue already. Now, if things happen like that, there is bloody outflow, or let's say brown outflow, well, that actually would mean that there is probably bowel perforation. Not good. Bowel perforation is going to cause peritonitis already, and it could possibly cause rapid septic shock into the patient. So this is something that you need to report to the physician right away. So this will call for an immediate halt of the PD. Make sure that the medical provider is notified right away. Do not wait even for 8 hours. You have to call them right away. Now, another is when there is yellow or urine color discoloration. Well, that simply means that there is now bladder perforation. That is not good as well. Again, that will call for immediate stop to the dialysis session, call the provider right away, and monitor the patient. Okay? We're going to have to check the patient for any manifestations of shock. Well, I have to ask you, what are those signs of shock? You're going to have to take a look into the latest temperature reading to see if there is elevation of their body temperature. As a normal response of the body, it will try to elevate its temperature to fight off the infection that is invading the peritoneal cavity or invading microorganisms into their bloodstream. Another is the heart rate. If there is an increase in the heart rate, or let's say if there is tachycardia, that is going to go with the temperature. It's going to go up. And same thing with the respiration. It will go up as well. And then During the early phase, the blood pressure will go up as well because this is one of its mechanism to compensate for the invading microorganism. It will be higher during the early phase, but during the later stage of shock, it will go down. Okay, so these are things that you need to keep an eye out if you're going to encounter these complications in PD. Now, we're going to have to take a little break here. So again, I am encouraging everyone to share our session with this 90 days of free NCLEX training classes. And so this is actually the second session that we have. And so there are many more days of classes that will be conducted through this channel. So I encourage you to share this video, and also make sure you like and subscribe so you'll be able to disseminate the information as well. And we are actually going to cover all those concepts, nursing concepts, with rationalization of at least 2,000 NCLEX style questions. So I want you to all get the benefits from what we are offering. And so we are going to conduct the classes every day at 12 p.m. Eastern Time. And so we don't want you to miss this opportunity. This is going to be free with the different tutors that will be presenting all of those nursing concepts. And we also will be conducting some NCLEX courses through the website. We have the www.stancoast.nclexcoaching.com. And so there's about 100 hours of complete NCLEX course there. And this will include a video course of about 10 hours, animated videos, lots of on-demand videos, 2,000 practice tests, and there's also going to be an audiobook for those NCLEX students, an ebook, a flip book, mock tests, and they're also going to be the access for about 6 months, and there will be 200 plus NG and test questions and self-paced courses that you can access anywhere, anytime. And I really want you to grab the opportunity because this month we are offering about 70% discount. So I really want you to check on the website right now. Now we're going to have to proceed with one question before we're going to end the session today. So I'm presenting here a common question regarding CKD. So the situation here reads: a patient with chronic kidney disease presents with metabolic acidosis. The assessment findings include deep, rapid breathing, lethargy, and confusion. Vital signs include blood pressure of 144/98 mmHg, respiratory rate of 28 cycles per minute, oral temperature of 99.8 degrees Fahrenheit, and oxygen saturation of 94% in room air. The lab results reveal a pH of 7.28, bicarbonate of 18 milliequivalents per liter, and we have a potassium level of 5.8 milliequivalents per liter. The creatinine level of 2.3 milligrams per deciliter, and a blood urea nitrogen of 34 milligrams per deciliter. The 12-lead EKG or ECG showing irregular rhythm in the 90s with peaked T waves. So which intervention should the nurse prioritize? Select all that apply. Okay? So I really want you to read through the situation because it's like a huge paragraph, right? But this is nothing compared to the case scenario that you'll be encountering in one of those standalone test questions. So again, just to make sure that you're grasping the totality of the situation, our patient with CKD comes in to your care with metabolic acidosis. So they're having some deep, rapid breathing. There's also lethargy, so that is significant. Their level of consciousness is diminished, so that is more than drowsy, right? So when you are talking to the patient, they're probably not paying attention. They're just kind of like dozing off and on, and then when they're going to call you, when you're going to call their name, they're going to wake up a little bit, and then they're going to go back to sleep. So that is what lethargy is. And they are confused. They are not there completely, meaning they could be confused to the time, the date, or maybe confused or disoriented to the place, or even maybe disoriented to self. They forget their name or forget their birthday. Now, the vital signs that we have collected, the blood pressure is 144/98. So, abnormal, right? 144, it's not really critical, but it's high. Respiratory rate of 28 cycles per minute, that is way over the allowed range in the adult. And oral temperature of 99.8, that is low-grade temperature, so considered low-grade fever. And the oxygen saturation of 94% in room air. All right, so I really want you to capture those. The lab results reveal pH of 7.28. So I want you to decide what that is. Is that acidotic? Is that alkaline? Or is that normal? With a bicarbonate level of 18 milliequivalents per liter, potassium of 5.8, creatinine level of 2.3, blood urea nitrogen of 34, and 12 lead EKG showing irregular rhythm in the 90s with peak tall T waves. Now you have to decide what nursing interventions that you could apply to this patient. I want you to decide right now. I'm going to give you a minute to select your answers. Select all that apply. So I'm just going to pause here for a few. So our choices here: administering intravenous sodium bicarbonate IV. We also have providing respiratory support with oxygen therapy. We have contact the dialysis nurse to start the hemodialysis. Administering intravenous regular insulin with D50. Monitoring serum potassium levels. Encouraging oral intake of high potassium foods. And also administering intravenous calcium glucose. And administer furosemide 40 milligrams IV. Increase oral fluid intake immediately. And we also have administering sodium polyestyrene sulfonate via nasogastric tube. Now I hope that you have selected your answers this time. So we will reveal the answers right now. Let me have my pen. So what are the answers? So one of those answers are, we're going to have to administer intravenous sodium bicarbonate. Why? The medication itself is basic in nature. It is an alkalinizing agent that you can give as an IV push. But in some hospitals, it can vary from one hospital to the next. It can allow the nurse to administer an IV push of sodium bicarb, or the pharmacist will prepare the infusion through a small bag of sodium bicarbonate, and this will be delivered as a piggyback, right? And so this will be run for maybe a few minutes or maybe a good hour, but it will depend on what the protocol is. And so the reason that we're giving the sodium bicarbonate, it's going to treat the metabolic acidosis. It will alkalinize the acidic blood pH. We talk about 7.28. 7.28 is very low. Normally, the lower limit is 7.35. So this is way below the normal range. And so with the patient's metabolic acidosis, this is one of the priority problems that we need to deal immediately. Why? Because when there is metabolic acidosis plus hyperkalemia, this is going to affect the overall state of the body system. It can affect the hemodynamics, the cardiac function, and also it can also affect the patient's mentation. That is why we have a lethargic patient. You have assessed that the patient has a Cosmos respirations, right? They have a rapid respiratory rate of 28 cycles per minute, okay? And so they have a rapid breathing. That's already a sign. That is the Cosmos respiration. Now, and we can give that sodium bicarb. That's one of the interventions. Now, let's see if the second option is correct. Provide respiratory support with oxygen therapy. That is also correct. As we are basing into our assessment, our patient has a saturation of about 94% in room air. They are having Cosmos respiration. Plus, we have assessed that they have some, did we see some crackles? JVD and bacillar crackles. Not a good thing to have. And so our patient really would need some support as far as supplementation of oxygen at this point. So it could be in a form of a nasal cannula in a low flow, maybe 2 liters or 1 liter humidified. So we can also start that with to the patient. And another thing is to contact the dialysis nurse to start the hemodialysis. Well, if there's already an order for the dialysis nurse to start, then we can coordinate with them. Maybe they can now start the dialysis session. So this is one of our collaborative function in order that we can assist the patient to have as early as much possible that we can give them the treatment that they need. Now, we're also going to check on administering intravenous regular insulin and D50. Why? Why are we administering the insulin plus D50? Well, the insulin that I'm talking about here is regular. It's not long-acting. It's not Lantus. It's not Levemir. Okay? We're not talking about NPH. We are talking about regular insulin IV. Okay? And this is going to be injected into the IV line of the patient, not subcutaneous, not IM. We are going to give it IV. And this is going to be given with a D50, which is basically 50% dextrose. And the reason that we are administering the insulin, it's not because that the patient is diabetic. No, we don't have that information. That is not the reason. The reason that we are giving the insulin with D50, it's because the hyperkalemia, wherein there is an abundance of the potassium ions in the bloodstream. We want to temporarily allow migration of the potassium ions in excess from the bloodstream because there is hyperkalemia, right? I'll just put here K+. So if the level here is elevated, like I've said, it's 5.6? Can't see from here. Somewhere around that. Anyway, it's hyperkalemic. Now, we're giving the insulin, it's because we will allow the movement of this potassium from the intravascular compartment into the cell. So the insulin will serve as the key in order that the potassium can enter into the cell through the sodium potassium adenosine triphosphatase channel. And so with that, it will temporarily move into the cell. So those excess potassium from the bloodstream will go inside the cells for a good 6 hours. Why did I say 6 hours? Well, because we are giving regular insulin. Please take note, guys, that the regular insulin will have a duration of about 6 to 7 hours or even 8 hours. So for that duration of 6 hours, the potassium ions will be staying inside the cells. So we are actually allowing the influx of this potassium, because if we're not going to do that, the patient will be endangered into developing life-threatening dysrhythmias. We don't want that. And so we're going to keep those the potassium ions inside the cell at this point. All right? Now, we don't stop our intervention there. There's so much more interventions that we can treat the hyperkalemia. Now, why are we giving D50? D50 is basically injectable sugar, right? That's dextrose. The reason that we are coupling it with the insulin, regular insulin, is because we don't want to cause inadvertent hypoglycemia in the patient, because, of course, insulin can cause hypoglycemia. So, in order to counterbalance, in order to prevent the hypoglycemic effect of the insulin, we're going to have to give the D50 simultaneously with the insulin. Now, we're going to checking on monitoring serum potassium levels, and that is also a good intervention. Why? Because we definitely need to monitor the serum potassium levels, which will help us identify if our treatment or interventions have been effective. So if your patient has, let's say, an order to have a follow-up blood draw for potassium level, let's say it's, what time is it now? 1 p.m. EST. And so Let's say, for example, the doctor wants to follow up the potassium level after you gave the D50 with insulin. Maybe they want you to have another potassium level, let's say around 6 p.m., because that would really tell you that maybe there is now a drop in or maybe 4 hours later on or 5 hours later on, maybe there is now a drop in the potassium level. So this is one thing to really monitor for any progression or a development of the patient's status. Now, another thing that we can do, what else? So here, encouraging oral intake of high potassium foods. Well, we can cross that off. We don't want any more of high potassium foods because, again, our patient is already hyperkalemic, right? 5.8, we don't want to add some more potassium into the system. So eliminate that. There's no use of introducing some more potassium. It can harm the patient. Now, let's take a look here. Administer intravenous calcium gluconate. Now, I really want you to remember in your pharmacology, what is the role of calcium gluconate in the treatment of metabolic acidosis with hyperkalemia? Ask yourself right now. Well, the reason for that is because the calcium gluconate can help stabilize the cardiac cell membrane potential. Because when the patient has hyperkalemia, the heart cells will be prone to be too excited. They will become too irritable. So with that, the patient will be at risk to developing life-threatening dysrhythmias. So this is another potential, or this is another problem that is going to be a high priority that needs to be addressed by the administration of calcium gluconate. So what does the calcium gluconate do? It will reduce the cardiac irritability. It will also allow some relaxation of those heart cells. And again, this is only a temporary intervention. This is not going to cure the patient. It will only prevent the dysrhythmias to occur. So our interventions do not end here. We still have more to go. Now let's take a look into, so let's check that off. What about this? Administer furosemide is 40 milligrams IV. So the furosemide is a loop diuretic. It is a powerful diuretic that can help get rid of the excess fluids inside the body. Now, I want you to review the scenario here that the patient has what? Positive JVD, which is basically jugular venous distension, which signify a fluid overload in the venous system. So when the patient has lots of fluid circulating into their body, their vascular system, the veins will engorge. And so even if the patient is sitting upright in semi-Fowler's position, you will see the jugular, the external jugular vein engorging, okay? So this is an indication that the patient is fluid overloaded. And same thing with the basilar crackles. This is a sign maybe the patient has an impending pulmonary edema, right? Because of its effect into the vascular compartment. When there is hypervolemia, remember about the increasing hydrostatic pressure? When there is increased fluid inside the blood vessel, it will allow the blood vessel to blow up. Not blow up like bursting, I'm just saying blow like it's enlarging, it's engorged, and it will cause the permeability of the blood vessel walls will be increased. So it will cause shifting of the fluids from the capillaries inside the lungs into the alveolus or the alveoli. So it will cause consolidation into the lung parenchyma or the alveoli. And so we really need to treat that with the use of the Lasix. But that's not just the reason that we are administering the Lasix. The Lasix is also powerful in treating hyperkalemia. I want you to think of this. Lasix and potassium are enemies. Okay? If you see anything in an NCLEX question, patient getting Lasix, and there they have their potassium level. Expect that the potassium will go down, right? And so with this, since our concern here is hyperkalemia, there is a need for us to get rid of the excess potassium ions from the body. By how? Eliminating the potassium ions by telling the nephrons, the Lasix will tell or trigger the convoluted tubules, the loop of Henle, to prevent reabsorption of the potassium in those structures. So it will get rid of those potassium ions. So it will resolve the hyperkalemia. Now let's take a look into the next option here. Increase oral fluid intake immediately. Now, again, I talk about the safety issue that we need to deal with. So if a patient in CKD, or let's say acute renal failure, maybe they have uremic encephalopathy, they are disoriented, they're confused, their mentation level is down, they are lethargic, they are drowsy, they are obtunded, do not initiate oral fluid intake. That is my advice for you as a neuro nurse. Do not put anything in the patient's mouth because they're prone to choking. They're going to end up with aspiration pneumonia. Never put any liquids into the patient's mouth if they are not alert, right? And so there is also no need for us to increase the fluid intake because they are already fluid overloaded, right? They already have the JVD, they already have the crackles, pulmonary edema going on. We don't want any more fluids inside their body. Now, let's take a look into the last option here. Administer sodium polystyrene sulfonate, or known as the Kayexalate. And it's said here via NG tube. Is this going to be a good intervention or not? Yes, it is. Our patient is lethargic, confused, and so there's no way that we can safely administer this medication through oral route. And so here our order is to administer it through the nasogastric tube. But why we need to administer Kayexalate? For what reason? Well, the Kayexalate is actually a medication. It will cause an exchange between the sodium and the potassium in the gut. It will pull all those excess potassium from the vascular system in exchange of the sodium, which is we are giving sodium polyestyrene. So again, I want you to recall the nursing implications or nursing responsibilities before we give the Kayexalate. First things first, take a look into the current level of the potassium. Now we're going to have to check for the patient's ability to swallow. If they're not, definitely get an order for an NG tube route or maybe enema. We're going to have to check for the bowel sounds to make sure that the patient has active bowel sounds, because if they're going to have absent bowel sounds and they're going to take the Kayexalate, it will cause the medication to stay longer inside their bowel, and it can cause necrosis into the intestine, it can cause perforation, it will lead into peritonitis. That is why we need to check for the bowel sounds first things first, and then we're going to have to check for the bowel movements probably 4 to 6 hours later on, and then a follow-up potassium level in order to check if our intervention has been effective. Now, in order for us to really be effective in answering those questions, I hope that you're able to at least answer 6 out of the 8 correct answers, because we have only 2 wrong answers here, and that is the encouraging oral intake of high potassium foods and also the increasing oral fluid intake immediately. So those are the 2 wrong answers. The rest are correct answers. So my test taking strategy for you in this test question is to assess the scenario holistically, okay? So I want you to review the entirety of the patient's presentation. I want you to look into the assessment findings, the vital signs, the lab results, and whatever subtle changes that have been described in the paragraph. I want you to capture all those. And part of that strategy is to identify those urgent needs. And I have mentioned that already. Our urgent needs are what? The metabolic acidosis. What else? We have the hyperkalemia, irregular cardiac rhythm, right? What else? We have the basilar crackles, and there's also the rapid breathing. Okay? And so these are the urgent needs that need to be dealt with accordingly. And so you have to prioritize those interventions that can target those issues. Now, also consider following the ABCs, the airway, breathing, and circulation, because first and foremost, that would be the focus of you in answering those questions. Make sure that we are maintaining a patent airway, breathing, the circulation. And so at this point, our goal here is to support the patient with oxygen therapy, and which is very crucial. And then we're also going to have to evaluate for those critical interventions, let's say administering the IV sodium bicarb, also administering the calcium gluconate to prevent the cardiac dysrhythmias, and also administering the furosemide IV to get rid of the excess potassium. What else? Collaborating with the nurse, the dialysis nurse, so she can do the dialysis treatment. The administration of the regular insulin with the D50 to allow the excess potassium to migrate temporarily into the cells. Now, let me backtrack here. All the steps, the interventions, the pharmacological interventions that I mentioned. So, like I've said, the sodium bicarbonate, the D50, plus the insulin injection, and also the calcium gluconate, those are, and also the furosemide, those are temporary pharmacological interventions. These will not treat the patient's metabolic acidosis, because potentially the potassium can go back into the bloodstream after the 6-hour period. That is why we are going to administer the sodium polystyrene sulfonate, or known as the kayexalate, because this will pull all those excess potassium from the bloodstream by allowing the person to poop out all those excess K ions. And also we have the dialysis, which will really get rid of those excess potassium. And so we're also going to have to prevent or eliminate those irrelevant options that can cause harm to the patient. And we have identified two, this one right here, encouraging oral intake of high potassium ions, and also administering or increasing oral fluid. This can also harm the patient. So these are not relevant to the patient's condition. It can only exacerbate the patient's metabolic acidosis and fluid volume overload, and also hyperkalemia. So I hope that you're able to learn something from this short session, and I will see you again in the next session, and we're gonna have another session tomorrow for at least like an hour or so, and we will be going over with another topic on the kidney transplant, and we're gonna go over with some Q&A as well. So I hope that you're able to learn something from this activity, and please make sure you share and subscribe this video and also the YouTube channel, and make sure that you're also encouraging your friends who are trying to pass for the NCLEX, make sure that they're going to participate in our session. So that is all for today. I thank you for your time, and you have a great day. Bye-bye.